Hello and welcome to the final episode of Med Table Talk. If you missed the first three, please check them out. I'm your host, Rashida Persinger, and I am a thoracic oncology nurse practitioner at the Sidney Kimmel Cancer Center in Washington, D.C., which is affiliated with the Johns Hopkins system. Today, I am thrilled to have joining me two expert colleagues. Blanca, please introduce yourself.
Thank you, Rashida, and thank you for having me here today. I'm Blanca Ledesma. I'm a nurse practitioner at UCLA Hematology Oncology in Santa Monica, California, and I focus on thoracic malignancies.
Thank you. And Tawana, can you tell us a little bit about you?
Thank you for having me again. My name is Tawana Bradley. I'm a nurse practitioner here in Atlanta, Georgia, with Georgia Cancer Specialists, an affiliate of Northside Hospital Cancer Institute.
Thank you again. A key role for oncology nurses is monitoring for and managing adverse events, and of course, educating our patients about them as well. Our discussion today will focus on engaging patients of diverse backgrounds in preventing and monitoring for AEs such as rash, stomatitis, diarrhea, and dyspnea. And we will also talk about strategies for mitigating these symptoms. So let's get right into it, okay? Blanca and Tawana, what are the components of diverse background? Is race something that drives you all when you're doing this assessment?
That's a great question, Rashida. I don't think race has anything to do with it at all. I think that a diverse background is a patient's cultural background, their religion, their socioeconomic background, their support group, distance. We really look at the patient as a whole, resources that are available. How easy is it for them to acquire these resources? Are they coming, via a bus? Are they taking several buses? Do they have to rely on family to bring them to us, or do they have a robust support system? These are the components that we look at for patients when addressing our diverse patient as a whole, rather than race.
I would agree with that. And Tawana, anything you would like to add to that?
Yes, we know we have diversity, but it's more on a cultural level, spiritual level. If they have health literacy, can they understand what I'm talking about? And so when we're having these discussions about treatment options and then talking about toxicities and adverse events, I think we all tailor our discussions depending on that patient's level of understanding, right? The most important factor for me is how can I best educate my patient based on their level of understanding. We tailor our discussions based on who we have in front of us. If it's someone who's more educated and may have a higher degree of understanding, then that's how you change your lingo and your terminology when you're educating them. If you have someone who may not be as savvy, you have to bring it down to more of a third grade, fifth grade level to help our patients understand so that one, they can make the best decisions for themselves, and then two, understand why we're doing what we're doing, and then be able to converse with us and explain to us the side effects that they're experiencing.
I think both of those are great points. The only time when I may even consider race is if a patient presents with a rash, right? And that is just in terms of darker pigmentation, right? We know that rashes are going to present a little different than our Caucasian counterparts. What I'm hearing from you all is that we're looking at more of social determinants when we're doing this education and helping our patients understand and how we're going to monitor and how we're going to mitigate. I think that's what is so important. And I am super excited to have Ms. Ivy Elkins, a patient advocate, join us to continue this discussion. Ivy, would you mind introducing yourself and the awesome work that you are doing?
Sure. Thanks so much, Rashida. My name's Ivy Elkins, and I've been living with stage 4 EGFR positive lung cancer for almost 9 years. I am actively involved in patient advocacy, and I'm one of the co-founders of the EGFR Resistors Lung Cancer Patient Group, where we support and educate patients and caregivers, and also try to help provide our patient perspectives with research as well. I live in Evanston, Illinois, just north of downtown Chicago, and I'm really happy to be here.
I really appreciate you joining us. So Ivy, let's just get right into it. We have some questions that we would love to get your patient perspective. What do you feel has been the best prevention information provided to you from your oncology team as it relates to adverse events?
The best information that's been provided to me regarding adverse events really has been advice in terms of how to be proactive in preventing these adverse events from happening or at least mitigating their impact. As a patient, I'd much rather do that up front as opposed to waiting until a side effect hits and then scrambling to figure out how to treat it. So, for example, I really like to eat big salads, but I recently started a new treatment that tends to unfortunately cause some diarrhea, especially with lots of fiber, roughage, that type of thing. So I was told that if I took a half dose of Imodium along with my salad, it might work really well to reduce the impact of the diarrhea. And that's been extremely helpful advice for me. So I still get to enjoy something, but I'm able to be proactive about the side effects.
That's a great point to make. And just to kind of piggyback off of that, how did your oncology team prepare you for what to monitor for? Was the discussion effective? And knowing that you are a very savvy, educated, and resourceful patient, do you feel there were some implicit biases in how they approached the topics with you?
Over the years, I've had extensive conversations with both the pharmacists and the oncology nurses who work with my oncologist prior to starting new treatments because I've been on 3 different targeted therapies. And that's been really helpful for me to learn about all the possible things to watch out for. But usually, when I meet with my oncologist, she focuses really on anything that is majorly bothering me due to, more limited time.
Right.
And with my newest treatment, I actually requested to also connect with palliative care for the first time since I was diagnosed. I tell people as an advocate about the importance of palliative care, but personally, I have not, connected with palliative care myself until recently. And although I've always known about it, this connection was actually never offered to me. And I think that's because of exactly what you just said, Rashida, some implicit bias that I am considered resourceful and will just ask for what I need. And since
Mhm.
I never asked for it, it's just kind of assumed that I am not interested or I don't need it. Well, I have to tell you, I found this extra time to discuss everything and anything that impacts my quality of life with palliative care to be so helpful. And I just really wish I had been advised to make this connection sooner.
That's a great point to make, Ivy. As we were developing these questions for you, I had to address my own implicit bias because I have those patients that are very savvy, comes with the journals, comes with the data to me. And I found myself sometimes, not all the time, making that assumption too. What would you say that could have been improved in your journey as it relates to prevention and, mitigating symptoms and monitoring and so forth?
I think it's so important to get palliative care involved with patients early on in their diagnosis. Additionally, to make sure that patients understand the difference between palliative care and hospice, because that's often confused when palliative care is mentioned. Patients say, oh, no, I'm not ready for that. And they don't completely understand that palliative care can help manage their symptoms at any time. Additionally, I wanted to emphasize that many need to be made aware of other helpful resources, such as, assistance that might be available with mental health issues or nutrition or exercise. And it's just so helpful to make these resources be known early on and proactively. And I just don't think that that happens enough and everywhere.
You just so eloquently, talked about the importance of palliative. I know that's something that we always stress, the importance of getting that on done earlier than later. I think taking back in my own practice is to make sure that I clearly delineate to my patients the difference between hospice and palliative. So therefore, they'll be a little bit more receptive to get into that palliative earlier on than later on. So thank you. Last thing, Ivy, what pearls would you provide to the oncology team to ensure we are more effective in educating our patients?
I would just say, to try to get to know your patients as people, as individuals, as much as possible, and just understand that they all might have different needs and varying degrees of understanding of this very confusing diagnosis that they've just been given. So to the extent that you can match the education and support that you have to individual needs, that is, incredibly helpful. And one last little pearl, don't forget to consider the caregiver and, their needs as well. They are very seldomly asked how they're doing, but also might need assistance and increased awareness of the resources that are out there.
Ivy, all I can say is thank you for taking time out. I know our audience is really appreciating all this information that you've given us from a patient perspective. Thank you so much.
Oh, it's my pleasure. Thank you so much for inviting me to be part of this today.
Yes, thank you, Ivy.
Thank you, Ivy. Such great information.
What great knowledge that Ivy provided us as it relates to how she's been able to, through her journey, the information that was provided to her to prevent some of these adverse events and how to mitigate it. I think that's a great segue for us to go into the most common symptoms. Let's just kind of give an overview of those common symptoms and how we would prevent or monitor and mitigate symptoms. To the audience, don't fret. Even though we're not going through each line that is presented, this will be also provided to you in a downloadable form. So therefore, you can utilize it in your individual practice. So when we look at rash, it's commonly seen in osimertinib and amivantamab. Does not mean that it's not seen in others. We've all talked about this throughout all of these episodes, that the major prevention is education, right? So providing effective education at baseline and throughout the treatment, monitoring during each visit, and also making sure that we ask open-ended questions. And then how do we mitigate it? How can we decrease some of the severities? We want to kind of catch it in that mild to moderate state, and making sure that patients have or know how to get in contact with us. And now, Tawana, why don't you speak on about nausea? What are some of the things that we can look at with that?
So I think we all know as oncology APPs and nurses that nausea is going to be something that we're going to face with many of our agents, right? And I think we've done a really good job at, really mitigating that and controlling that for our patients. We can see it commonly with sovatisib, tepotinib, capmatinib, and trastuzumab deruxtecan, right? But it's important that we prevent the nausea, right? Because that's what's really going to help our patients stay on therapy for the long haul and make sure that we're assessing this prior to even starting patients on therapy to see if they've had any existing nausea, if they're having any anticipatory nausea, because that sometimes can be a major factor, right? And you want to look at if they had any previous history of, morning sickness. You want to talk to their care team because sometimes they tell you way more than the patients ever will. I assess them each visit. I make sure that they all have some type of antiemetic at home to have in their arsenal. But also talking to them about dietary modifications, if there's lactose intolerance going on, making sure that there's not a conflict there. And then we're talking about in terms of pharmacotherapeutics, right? Patients can do some ginger supplementation, as well as acupressure or acupuncture, which I absolutely love. And just making sure that we're sending these prescriptions over and assessing if they can even afford the medications. If they can't, connecting them with resources to help them acquire the medication. Along with nausea, we know that we can sometimes see diarrhea. Mm-hmm. And diarrhea commonly occurs with osimertinib, mobocertinib, sotorasib, celeprocatinib, and trastuzumab deruxtecan. So again, we know that knowledge is power. Education is going to be key. Okay. So here you may be talking to your patients about doing the BRAT diet, right? Staying away from spicy foods, frequent smaller meals, avoiding alcohol and caffeine. In the event that a patient is having some diarrhea, we do our due diligence and we rule out to make sure that one, there's not an infectious process, it may need us to have to check their electrolytes to make sure we don't need to do replacement there, but also encouraging them to stay hydrated. And it may even mean bringing them in. I don't want them to get to a grade 3. I want to know about your diarrhea when it's a grade 1, because when you get to grade 3, it might be, too late behind the 8 ball to try to catch up. And so counseling patients and saying, when you start having, more than 2 above your baseline, go ahead and call me. I think our next will be Blanca discussing edema.
Thank you, Tawana. So edema is a unique adverse effect to these newer agents, such as more commonly with tepotinib and capmatinib. And where are they at baselines and how do they deviate from baseline? And we inform them the potential for this edema and empower them to have mitigating strategies at home should they have any edema. But really the importance of communication, that we start communicating with the patients at the onset of any edema beyond their baseline. I like to grade patients standard of care and clinical trial so I know what my intervention will be. And based on the package insert, we can determine if we're going to monitor, we're going to intervene. If a patient has a persistent, intolerable grade 2 edema or higher grade edema, that we can follow the package insert and consider if we want to hold a dose reduced based on patient's severity.
Yeah, that's really good, Blanca. Things that you both mentioned that we cannot minimize, the importance of grading, because what that does, that helps the next person who sees that patient, they can know what that symptom was. So they don't have to do any guessing of mild, moderate. If you grade it, it just makes it easier for the next provider. But I have the pleasure to talk about hypertension now. And so when we see hypertension, again, it can happen in other agents, but commonly occurs in selpercatinib, as it has been mentioned before, is that effective education, knowing that patient's history. Are they coming with pre-existing hypertension? Is it controlled? We want to make sure that they know to monitor it at home, and making sure that they know how to utilize a blood pressure cuff. I think we do a disservice when we expect patients to check their blood pressure at home. Well, we don't even know if they know how to use it correctly. So these are questions that we have to ask. We want to make sure that we're optimizing good blood pressure control prior to starting treatment, which will minimize some of those symptoms. And also, if need be, increasing blood pressure medicine through their journey. We're pulling in the primary care as well that can help us in managing. And then lastly, I would like to turn it back over to Blanca.
So dyspnea is a common adverse effect that we can see with many of the treatments that we've already covered in episode 3. It's important that we really, again, evaluate patients' baseline. They may have a baseline shortness of breath, dyspnea, cough. If they have a deviation in their baseline, we need to start communicating and start evaluating for potential contributing factors. Is it disease progression, infection, a thrombotic event like a PE? And of course, we want to start doing imaging and evaluating for potential ILD pneumonitis. So we want to treat ILD pneumonitis per standard of care, but each individual treatment per the package insert will have different guidance as to whether you want to hold, dose reduce, permanently discontinue based on the severity of the grade. Rashida, I'll send it back to you.
Thank you. That was some great information. And so these are resources to help oncology APPs and nurses provide effective education. And then we also have resources for our patients as they go through treatment. It wouldn't be an APP, an oncology nurse presentation or discussion without pulling it all together in a wonderful case study. I learned so well when I can bring everything back together. We have Miss Waters. She is a 55-year-old woman recently diagnosed with stage 4 adenocarcinoma of the lung with mets to the liver. She presents to the office to review recent next-generation sequencing, NGS, results with her oncologist. The test results confirms a RET fusion. Her medical history is that she has hypertension, currently controlled with lisinopril 10 milligrams daily. She was started on selpercatinib. Her weight is 52 kilograms, and we know that selpercatinib is weight-based. Tawana and Blanca, so based on Ms. Waters' history and understanding the safety concerns associated with selpercatinib, what are the best strategies for preventing and monitoring AEs?
The best strategy is education for prevention of any adverse events for Ms. Waters. Potential of nausea and vomiting with the sulfatinib, and she's already on an antiemetic. We have to be cautious that she already has maybe potentially a baseline nausea, or if she has further added nausea with her treatment, that we do monitor her weight because she can go below 50 kilos and we would have to dose adjust her and reduce her treatment dose. Further, we want to be cautious of the QTC prolongation, as well as her history of hypertension, ensure that she has the ability to have access to either a blood pressure cuff to evaluate her blood pressure at baseline before starting treatment and keep a log, or setting up those expectations of the potential adverse effects, what to look for, and the importance of prompt communication so that we could do prompt intervention if we need to adjust her medications to control her blood pressure, her antiemetics, her sulfatinib dose.
Great point. Tawana, anything you would like to add to that?
We took into consideration, the dynamics of her family life right now and being probably the breadwinner, worrying about stress and her previous history of hypertension. We may have to consider putting her on another agent. We may need to get her set with our counselor. That may help control the stress. And then she'll have an outlet or someone she can talk to that's non-biased. And that may even help her to support her to be able to stay on therapy.
And I think that's an important thing that you said in terms of stress, because stress will directly affect the blood pressure. So Ms. Waters returns 1 month later, and she reports episodes of diarrhea over the course of the last week. She states only taking antidiarrheal medication once a day without relief. She expresses concerns about being able to meet her job requirements due to the frequent bathroom breaks that she's been having to do over the last week. So Tawana, we'll start with you. What are your next steps?
Because if we don't get this under control, then this is really going to impact her livelihood and her being able to continue to sustain her family, right? And so I think we have a couple of things we need to discuss here. One, we talked about grading not too long ago, and just, we say 3 to 4 episodes of diarrhea over the course of the week. How was that in terms of grading, right? So you want to counsel her about that, keeping a really good log, staying hydrated, find out exactly how she's taking the anti-diarrheal, right? She's taking it after every episode. Patients get so worried about being blocked up, right? And so just counseling and letting them know that, when it becomes too hard, we can always pull back. But in the meantime, we need to, may need to take this a little bit more frequently. And if that doesn't work, we can always add some loperamide and maybe even some other medications to help with the diarrhea, talking to her about what she's eating. In regards to feeling fatigued and weak, remember, this is a mom, a wife of these 2 small kids. She's working full time, so she's going to be tired. Her treatment is also tiring. I usually tell my patients it's okay to take a nap, not longer than 30 to 60 minutes, because after that, get your circadian levels off. Resting is going to be key. We may need to inquire if there's any siblings or family members or church friends who can come in and help in terms of maybe doing some groceries and not feeling too prideful to ask for help. In terms of her job, this is a reality for a lot of our patients, right? And it may take us having to help get short-term disability, complete paperwork for FMLA, but really just trying to stress this. Ms. Waters, continue to have this open dialogue with us. We will do our best to try to help manage these side effects. You work as best you can at working on controlling your stress and staying on top of everything you possibly can within your control, and then asking for help.
Blanca, anything you would like to add to that?
Yeah, I wanted to add a couple of more things. I just would love to bring her in and draw some labs if she's not able to come in because she only has one vehicle. Maybe perhaps have her get labs done locally and maybe make sure she's not dehydrated, she's not having an electrolyte imbalance that's further contributing to her fatigue. And if there is, that we correct those electrolyte imbalances. If she needs to have some perhaps IV hydration to help support her, that we do set her up for that. Additionally, reinforce the importance again of where are you at baseline with your bowel habits? How are you deviating from baseline? And the minute there's a deviation, that we need to start communicating. We should have been communicating at the onset of the diarrhea. I'd rather over communicate than under communicate.
You all made some great points. I think how this case kind of relates to all these new target, new novel therapies is the importance of educating, open communication, identifying which mode of communication is best for our patients. This case could be any of these new drugs, but the takeaway would be the same. educating, open communication, so we can do the best for our patients.
Absolutely. Absolutely. Good points.
So, ladies, as we begin to wrap up this last episode, let's focus for a moment on what we would like to see in a perfect world. So, as we've closed out on all of our episodes, Blanca, in a perfect world, what would you like to see?
In a perfect world, we would be well informed with these targeted treatments. And so in turn, we can educate our patients, inform them of the potential adverse effects that they can potentially experience, know how to be proactive, have the appropriate resources on hand. If patients have more limitations in acquiring these resources, that we would have ample time to assist them in acquiring the resources they need to be empowered to mitigate these potential adverse effects.
Tawana, we make this assumption that everyone is living and breathing lung cancer, but let's be real, right? Most of our colleagues are most likely in a community-based practice, right? In a perfect world, we keep everybody in mind in terms of how we're going to educate, kind of like what Blanca is saying, to ensure that they have the necessary information. When we are planning the strategies for how to prevent, how to monitor, how to mitigate these AEs, that we don't negate to know who our patient is. What are their social determinants? Are there anything that could inhibit them from doing or coming on a regular basis? Or do they have Wi-Fi? Do they have a smartphone? Some things that we automatically take for granted, as well as those implicit bias, not just on those who are on a lower social economic, but those who may be very savvy.
I totally agree, Rashida. Ivy brought such great information for all of us. We're in this big pot of these complex, patients, complex diagnosis, and taking all those things into consideration, but really truly getting to know who the patient is. And I love when she said getting to know who their caregivers are, right? Because they're a part of the care team as well. They're helping us help the patients stay on treatment, get to appointments, and we need to take all those things in consideration. Like you said, transportation, level of education, health literacy, and then bringing that together to them to help them to understand this is the treatment that you have. Here's why you're getting it. Here are the side effects. So that would be a perfect world for me, is that we could all come together to make sure that these patients are well-versed and understand exactly what we're doing. And so with that, guys, this is the end of this episode. We thank you all for participating. And as Rashida has already mentioned, we have several resources that you can download from the Activities website. Please check out the first 3 episodes of MedTable Talk if you haven't already viewed them. I hope that you guys have learned a lot. To get credit for this activity, complete the post-test and evaluation. And again, we thank you guys for this opportunity. Thank you.